Hi, my name is Gabrielle DuBruille, the current PGY2 Cardiology Pharmacy Resident at Prisma Health, and today I'll be presenting my research project titled Optimizing Utilization of SGLT2 Inhibitors in an Outpatient Heart Failure Population. I would like to thank my investigational team for their time and support throughout this process. The authors of this presentation have the following to disclose. And by the end of this presentation, you should be able to identify appropriate criteria for initiating an SGLT2 inhibitor in a patient with heart failure with reduced ejection fraction. For the remainder of this presentation, when I refer to heart failure, I will be referring to heart failure with reduced ejection fraction. We will begin with a brief background. As many of us know, SGLT2 inhibitors are now recommended as backbone guideline-directed medical therapy per a new 2021 heart failure consensus statement. This consensus statement specifically recommends empagliflozin or dapagliflozin due to the two recent trials, DAPA-HF and EMPEROR-Reduced. Empagliflozin is recommended if your eGFR is above 20, while dapagliflozin is recommended if your eGFR is above 30. According to a recent heart failure registry, 81% of studied patients were candidates for dapagliflozin therapy. Therefore, this registry concluded that SGLT2s have very broad generalizability to clinical practice. An MUE was conducted at Prisma Health Richland in their outpatient heart failure clinic that assessed SGLT2 inhibitor utilization. This MUE demonstrated very poor utilization with less than 1% of patients on therapy, while a large portion of patients were candidates for therapy. After this MUE was performed, a pharmacist-led education program and initiation protocol was developed. The goal of this program was to educate heart failure providers about the morbidity and mortality benefits associated with SGLT2s, as well as create a protocol that identified candidates, helped select drug therapy, involved patient counseling, follow-up, and monitoring. Therefore, the objectives of this research project were to assess the impact of a pharmacist-led provider education program and initiation protocol on SGLT2 inhibitor prescribing, as well as to determine barriers to utilization. This study was a single-center retrospective cross-sectional cohort of an outpatient heart failure population that included both LVAD and non-LVAD patients. The primary outcome was a proportion of patients on therapy prior to and after pharmacist-led provider education and protocol development. As you can see, in May and June of 2019, this is when that MUE was conducted that assessed patients on SGLT2 inhibitor therapy. Post-MUE, this pharmacist-led program and initiation protocol was developed, and then finally, 1 year post-MUE, patients were reassessed to see if SGLT2 inhibitor therapy was initiated. Patients were considered to be a candidate for SGLT2s if they were NYHA class 2 through 4, had a systolic blood pressure above 100, or for our LVAD patients, a MAP above 80, and an eGFR above 20. Moving along to results, as we can see, the majority of patients in this study were NYHA class 2 through 3, with a significantly more amount of patients being NYHA class 3 in our 2020 cohort. Patients had relatively stable hemodynamics with an average systolic blood pressure in the 120 range. Less than half the amount of patients were diagnosed with type 2 diabetes, and as you can see, a significantly larger amount of patients in the 2020 cohort were on guideline-directed medical therapy compared to the 2019 cohort. Moving on to the primary outcome, if you recall, this is the proportion of patients on therapy prior to and after protocol development. If we first look at these first two bars, the 2019 section, we can see that 1% of patients were on SGLT2 inhibitor therapy. However, there were a very large amount of candidates. 73% of patients were candidates for therapy. If we compare this to 2020, we can see a significant improvement in our on-therapy patients, with 16% of patients on therapy, compared to our candidates, which is reduced to 50%. As you can see on the right-hand side, a significantly larger amount of patients were on therapy in 2020 compared to 2019. The most common reason for patients not being on therapy included patients that had a relatively low eGFR, less than 20, and patients with a systolic blood pressure of less than 100. In this study, we also assessed barriers to utilization. Patients were less likely to be placed on an SGLT2 inhibitor if they were above 60 years old and had a recent heart failure readmission in the last 6 months, as well as patients with an eGFR less than 45. However, patients were more likely to be placed on SGLT2 inhibitor therapy if they were a type 2 diabetic or on concomitant ARNI therapy or an aldosterone antagonist. Finally, in conclusion, a pharmacist-led provider education and initiation protocol significantly improved prescribing rates of SGLT2s, as well as additional guideline-directed medical therapy, including RAS inhibition and beta blockade. Targeting specific patient populations, including our older patients and patients with a recent heart failure readmission, may further improve prescribing rates. And finally, as a large portion of patients continue to be candidates for therapy, pharmacists play a vital role in improving utilization. I would like to conclude my presentation with a self-assessment question. Which of the following criteria is or are required to initiate empagliflozin in a patient diagnosed with heart failure? A and C are both correct. Remember, for empagliflozin, our eGFR must be above 20, while for dapagliflozin, our eGFR must be above 30. And remember, our NYHA class 2 through 4 is a requirement for SGLT2 inhibitor therapy. Diabetes is not required to be initiated on therapy. Thank you for your time and listening to my presentation on optimizing utilization of SGLT2 inhibitors.